Hey everyone, this is Dr. Madden's group and we're here to present our case study number 2 on our adolescent named Mackenzie. Mackenzie is a 10-year-old that was referred to us by her PCP. On interview, the mother reported that she worries about bridges, her father's travels, the future, middle school, high school, traveling too fast in cars, becoming ill, developing cancer, and whether her teachers are angry with her. Mackenzie cannot spend the night at friends' houses, she cannot go to birthday parties without her parents, and is only able to remain in church for about 10 minutes every Sunday. Her parents noticed her anxiety symptoms about 3 to 4 years ago, and it has progressively worsened. She lives with her mother, her father, and a younger sister, aged 3. Denies food insecurity, lives in an apartment near the school. Birth history was normal. No toxic substances, weighed 7 pounds when she was born, denied head injuries or hospitalizations. She does report frequent headaches and stomach aches when going to school, but not during the weekends, except on Sundays when it's time to go to church. On our assessment findings, her SCARED screening tool, she scored a 52 with the highest score. She scored 20 points in the section that suggests a diagnosis of generalized anxiety disorder. Any score over 25 on the SCARED tool suggests the presence of an anxiety disorder, and a score over 30 indicates a specific diagnosis. Her mother was diagnosed with anxiety in the past. Her grandmother was diagnosed with hypertension as a medical. She has no remarkable social history, denies drug or alcohol use, no smoking or vaping, no caffeine use. She does not have social media, as well as she enjoys a variety of crafting. No reported history of abuse. Her physical assessment was unremarkable. All findings were within normal limits. Her MSE was normal, and she takes a multivitamin daily. She does report an issue falling asleep, but does not wake up when she does fall asleep. Denies having nightmares. The diagnoses that we considered were generalized anxiety disorder, social anxiety disorder, and agoraphobia. We chose social anxiety disorder as a differential diagnosis due to her fear of going out into public and not being able to be at church for longer than 10 minutes, nor being able to attend birthday parties. We also chose agoraphobia as a fear of something specific, potentially social situations, but overall we decided to go with generalized anxiety disorder. The DSM-5 requires that symptoms be present for at least 6 months, and Mackenzie has had symptoms for 3 to 4 years. Children with generalized anxiety disorder are overly concerned about potential disasters and have significant distress in activities of daily living. Mackenzie meets the criteria for generalized anxiety disorder due to her screening on her SCARED tool of 52. She also has excessive worry about many different types of situations, current events as well as events in the future. Mackenzie also experiences problem with falling asleep at night, and she presents physical symptoms including the stomach ache and the headaches when it comes to attending school, going to church. She also fears developing an illness as well as her father's travels. The treatment that we had decided for childhood generalized anxiety disorder is starting Lexapro 5 milligrams PO daily. We will offer a follow-up in 2 weeks for an initial appointment and then in 1 month. If the patient is tolerating well, we can increase to 10 milligrams a day. Side effects to note would be decreased appetite, nausea, diarrhea, constipation, and dry mouth. We would also want to look out for activation when providing an SSRI to an adolescent. We would educate the family on to expect sleep, energy, or hunger may improve in 1 to 2 weeks, and sadness and lack of interest in activities may need 6 to 8 weeks for maximum improvement. Most side effects will improve after the first week or 2 of treatment, but to contact the provider if any of those persists. We are also going to make it a point that we would like the patient to seek cognitive behavioral therapy. It is the first-line treatment for childhood anxiety disorders, and it is highly recommended. A combined treatment of CBT and an SSRI has been found to be very effective in the treatment of childhood anxiety. Therefore, we are moving forward with the treatment of SSRI with CBT due to the length of time she was experiencing experiencing anxiety symptoms. Family education and family therapy is also going to be suggested to increase the familial support and the efficacy of treatment. Our follow-up plan is always going to be to monitor blood pressure, specifically with Mackenzie's family history of hypertension, as well as that's something you would want to look for when starting the SSRI. We also want to pay attention to the weight due to weight-based concerns with prescribing medication with adolescents. And we would want them to report signs of increased anxiety or withdraw from social activities. Take the medication as prescribed and do not stop abruptly. We would also suggest that any signs or symptoms of suicidal ideation or behavior be reported immediately for a sooner appointment. We also want the family to begin CBT treatment along with the family therapy within a week of starting the SSRI. Our evaluation of Mackenzie's prognosis were her strengths were that the family is seeking treatment. She denies bullying in school, denies any issues in school, doesn't use any social media, a relatively healthy adolescent child. Her family is intact and supportive, as well as denies any adverse child events. Challenges we suspect will happen is the family history of anxiety of the mother. The father is away due to travel. The patient is a little underweight and would need to address nutrition, as well as family therapy and education appointments would be hard with the father's employment and intermittent absence from the home. A big factor that we are considering is that due to the patient spending most of the time at home with the mother, who also suffers from anxiety, could negatively affect the behavior. Our group, during our discussion of this case study, the several things that we weighed back and forth before making decisions were, would an SNRI or an SSRI be a better choice? So we did go back and forth between duloxetine and the Lexapro, as well as when we decided to choose an SSRI, we went back and forth between the Zoloft and the Lexapro. We also had a conversation about ruling out social anxiety disorder due to the patient feeling comfortable at home, not having too many symptoms while at home, versus the generalized anxiety disorder, which is what we ultimately chose. Thank you for viewing our presentation.